Right here you go. Here is this. Do you want this? Eric. Are you going to take care of the building? And the projectionist knows back there, he'll handle it.
Where is the
Here, he's got it right here.
We're going to put this microphone on, you know. All right. Just put it around, get it. This is, I could work this for you if you like.
I'll have to be turned around later after my introductory remarks so I can see what's the screen and read off it.
Okay, I think we can begin now. First of all, I want to welcome everybody to the third Albert K. Says Microbiology, Immunology lectureship. This lectureship is sponsored by the Department of Microbiology and the International Center for Interdisciplinary Research in Immunology. It was established 4 years ago. It was started 4 years ago when Dr. Sabian stepped down from the chairmanship in the Department of Microbiology. It was set up by his students, friends, and associates to honor a man who has made numerous contributions to the field of microbiology, but more importantly to Georgetown University Medical Center over this past 25 years. Now, I'm sure most of you here know Dr. Saz, but I would like to ask Arthur if you would stand up and be recognized for those who don't know you, and I'd also like to ask Ruth Saz also to stand up and be recognized. You may not know him with the tie, absolutely. This year is a particularly significant year for the lectureship since Dr. Saz is formally retiring from the university after 25 years of service, as I said, to the Medical Center and to the Department of Microbiology. We all wish him well, we're all going to miss him, and we've all certainly have enjoyed our association with him. We are particularly pleased this year. We have had 3 lectureships, as I had mentioned. The first lectureship, our guest speaker was Dr. Robert Chanik. The second lectureship was Dr. Stanley Plotkin. We are particularly pleased this year to have Dr. Albert Sabian as the lecturer for this third lectureship. And I'd like to call on Dr. Belanti, if I may, to make a few introductory remarks about Dr. Sabian before the lecture.
Thank you, Gary. I think in the interest of time, I will not speak to all of Dr. Sabian's contributions. I have a long list of papers here that I could have read, but in light of the situation today, and this is a rather unique situation, and I might say one that we have not encountered before, but it's obvious that Dr. Sabian is hospitalized here, but wanted to give this talk today because of the importance of it and because of his commitment to being an invited lecturer. Dr. Albert Sabian, when the definitive history of the 20th century is written, the achievements of medicine will occupy a significant place, and within that history, Dr. Sabian will occupy a preeminent position. Today, throughout the world, he is one of the most recognizable names, and justifiably so. A quarter of a century ago, Dr. John Paul, the Emeritus Professor of Preventive Medicine and Epidemiology at Yale University, wrote, "In the history of poliomyelitis, no man has ever contributed so much effective information and so continuously over so many years to so many aspects of poliomyelitis as Sabian." End of quotes. He is an indefatigable worker. He has brought to the task a formidable array of intellectual talents, propelled by enormous drive, discipline, and energy. And I think today's example is a living example of that energy. In addition to his contributions in polio, Dr. Sabian's work has been noted also for fundamental studies on other viruses and other microbial agents. And today, we will hear of his most recent work, which involves the work on the eradication of measles virus, killer of millions in developing countries, and he will give us a strategy for rapid elimination and continuing control. Dr. Sabian, it is an honor and a privilege to introduce you today. I give you Dr. Sabian.
Gary and Joe and dear friends, this lecture is for Arthur Zass, a man still only 70 years old, quite young by my standards, who has devoted his life to advancing microbiology by teaching and by research. After receiving his PhD from Duke University 45 years ago and serving in the Army of the United States until 1946, he finally joined up with the National Institutes of Health for 15 years and thereafter served as chairman, as you've heard, and professor of the Department of Microbiology of the Georgetown University School of Medicine and Dentistry from 1964 to 1984. During a short period between the end of 1982 and early 1983, he very kindly provided me with a small office and some secretarial help in his crowded department, which I understand he now occupies himself as a continuing professor of microbiology. My acceptance of the invitation during a period of relatively poor health many months ago was an expression of my best wishes for many years of gratifying work and for happy years ahead for you, dear Arthur. Now, unfortunately, my health became worse recently, and I had not yet written out the lecture. And contrary to the advice of physicians whose judgment I greatly respect, sitting here in the front row, whose judgment I greatly respect but often question, I am here now in this fine hospital both as a patient and a lecturer. The subject of this lecture is part of my unfinished business. I suppose when my final day comes, I still will have unfinished business. the conquest of measles, a disease that I said in my title is a killer of millions of children in developing countries, from the disease itself and complications. The world doesn't get excited about a disease that kills about 20 million children in 10 years, but does get excited about an important, but nevertheless relatively limited disease that kills only about, let's say, 60,000 during 20 years. And measles isn't the only thing that kills more people than people realize. Now, just so you won't think I made up those figures myself, I'm going to start now with a series of slides. And the first slide will show about what the World Health Organization in its January 1988 statement said. I'll have to watch what goes on and see if I can read. And can I have the pointer now? If you want to read ahead of me, you can, but may I have it? All right. Now, as I said, what am I doing? I'm too weak?
It's on. There it is.
Ah, okay. It's from the WHO Weekly Epidemiological Record of 15 January 1988. And they said an estimated 2 million children die annually, and have died from measles and its complications. And delayed mortality, put the light out, it's better, thank you. Delayed mortality occurring up to 12 months after infection causes many more deaths. Measles control is made difficult because of continued disease transmission in areas with moderate to high coverage, and a high incidence of measles in children less than 9 months of age. Of course, I've always disagreed in one way or another with WHO, but I will not argue about their estimate of the situation, but I will argue about the fact of what is made difficult. Measles control in the world, according to data that I will show you during the rest of this lecture, is made difficult because the system and strategy that must be used in the developing countries cannot be the same as that has been used in the United States or some other developed countries. Next slide, please. Now, I'm sorry, maybe some of you can read it and some have not, but I will. This is an example that says measles rapid elimination of measles can be done, and was first achieved in 1967 to 70, about 20 years ago. Now, what did Dr. Fagin and his associates do in that period? Gambia, 20 years ago, had a total population of only 400,000. And they had some mobile teams which couldn't go to all places in the Gambia at once, so it was divided up. This is only the data for the Western Division. Now, they carried out the surveillance themselves. It doesn't depend on reporting. In 1967, during the first 20 weeks, 1 to 20 weeks, before mass vaccination, they had uncovered 1,248 cases of measles. And they went from house to house, and it was done slowly, and it took 12 weeks. And during the mass vaccination, another 809 died. After the mass vaccination. In the next 20 weeks, it dropped. Maybe it would have dropped anyway. 1968, the following year, they didn't carry on. They had no system for routine vaccination in between. The team came back to revaccinate all those who were not vaccinated in the previous campaign. And before and during the second campaign, the first 32 weeks, there were 16 cases uncovered. And after the second campaign, I neglected to say what the campaign included. It included children from 6 months, mind you, this is 67, 68, to, there are different statements, to the end of 3 years or under 6 years. But at any rate, all those were done, those new ones who were born. And during the subsequent 20 weeks, there were no cases. And during the third campaign, the same way, nothing in between the 12-month intervals. There were 2 cases during the 32 weeks, nothing in the 22 weeks after, and 2 again. Now, what were these 2, 16, 10? Do these represent the impossibility of breaking the chain of transmission, of interrupting it in microfoci of transmission? Or do they represent, as Faggy believed, introduction of new cases from nearby the Gambia that did not spread? Or, from what I've been learning since, did they represent measles cases that are diagnosed as measles by clinical methods, but actually are not measles when you try it by specific methods? Try to identify and confirm. Now, what is a specific method? Because I'll come to that later. Again, it wasn't available then. Fortunately, immunoglobulin M, IgM measles antibody, occurs during a brief period of infection, sometimes during vaccination, although not as much, and then disappears. So that all people who have antibody against measles because of previous illness or immunization don't have it. They lose it. So the presence of IgM and a clinical syndrome compatible with measles is the best proof that we have. Then, after 1970, they didn't have money. They weren't able to continue. Within 2 years, it was all back again like this. Because the new generations of children who were born were not vaccinated properly by routine methods. Unfortunately, this lesson never sank in. And routine methods were based on methods that are being used in developing countries. Next slide, please. I can say more, but I think I'm not watching my monitor, not watching my pulse. When I get a little too emotional, then I'll cut down. Thank you. Now, what did the World Health Organization do after this period? Gambia in 1974, many of you know, some of you don't. There was established a special group called the Expanded Immunization Program. And what they tried to do is to always bring up the percentage of vaccinated children to break the chain of transmission, and also to concentrate on the first year of birth. And unfortunately, with the subcutaneously injected vaccine, what could be done is that vaccination could not be started before 9 months of age, because maternal antibody prevented proper infection by the live measles virus vaccine. Now, I shifted my studies to Brazil because Brazil had started early in trying to vaccinate as many children as possible during the first year of life. But it seemed almost, now incidentally, what I'm giving you here is the total number of reported cases. And I'm not giving you the number per million total population, which changes quickly. And also, I'm not telling you here because I have no data for all of Brazil. But in the United States, in the pre-vaccine era, there were 10 times more cases of measles than were being reported. So when 400,000 were being reported, it could be officially to CDC, it could be shown that at least 4 million had it, you see. Now, there was a survey finally done in the state of Sao Paulo, but reporting is different. They were based on hospitalized cases. At any rate, the probability that there were 50 to 100 times more cases than are shown here, actual numbers of cases. And they were spending more and more, injecting more and more measles vaccine. There were only about 3 million new children born a year, but the more vaccine they injected, the more cases seemed to occur, very likely without being funny about it, because reporting increased. So now let's see the next slide. When you look at it critically, on the basis of the average number reported per year per million total population, that's the only way you can keep up with what happens in a growing population. But Brazil did something else. In addition to giving vaccine in mother-child health centers, in addition to giving it in clinics, in addition to private doctors giving it, Brazil had already introduced in 1980 what are known as the annual days of vaccination against polio, in which they've achieved great success in eliminating polio. So they thought, since from 1976 to 1983, that didn't seem to, obviously a certain number must have been protected, but you must remember that during routine vaccination, measles vaccine can lose its potency when the temperature goes down in the refrigerators, and they open a bottle to vaccinate one child, and then they put it back, and there are all sorts of problems. Well, at any rate, in many states, they started giving measles vaccine to children from 9 months to 23 days of age, months of age, during the days of polio vaccination in 84 and 1985. But nobody's made a checkup, a follow-up to see what it did, what was the impact. Well, I like to go to Brazil anyway. I went every year, and I got some figures on the number per million. And there are variations, although these are 10-year averages, 5-year average, or 4-year average. But you see, in 1984 and 1985, although not all states, 22, 23 states in Brazil did it, there was no impact on the total number of cases. And as you'll see in the next slide, no, I guess it was in the previous slide. May I have the lights, please, for a moment? The previous slide showed that for 1986, after 2 years of intensification of that, may I have another sip of water, please? Brazil in 1986 had one of its most severe epidemics ever since they started vaccinating. Well, a friend of mine who was a professor of public health, the School of Public Health in Rio, was appointed the Secretary of Health for the state. And what I was preaching, because that's what it amounted to, I had no proof, was that what one needed to bring a rapid change in the picture of the numbers of susceptibles was not just to do as much as possible year-round vaccination, in which you are running a competition with the naturally occurring virulent measles viruses, and having some that get vaccine that is poor or not at all. That what is needed is to do very much what was done in polio, namely to first give vaccine to all those in the particular age group for a country, regardless of whether they'd had a history of polio, which meant nothing, or vaccination. Well, this gentleman, Dr. Eduardo Costa, had decided that in May 1985, a special measles campaign would be set up independent of anything else that will be done. And that all children from 9 months to under 5 years of age would be brought by their parents, and they would not be asked to see their cards. Do they have an indication that they had been vaccinated? They weren't asked, did they ask their mothers, did they have measles? They just asked how old this child was. And a very large number received vaccine. What's a very large number? Very large number means nothing. There's a problem. The municipality argued with the state, and they said, to hell with you, we've got good enough coverage. We won't do it. And the state of Rio de Janeiro had then about 20 million people. 5 million in the municipality, roughly 7 million or so in the state, in the interior. The interior of Rio de Janeiro is quite a big country. But they already had the experience of organizing volunteers, training them how to do for the polio programs. Well, at any rate, this mass vaccination was carried out. Many children came in from the municipality to get vaccinated, despite the fact that it wasn't officially done there. And then I arrived on the scene to see what happened. They didn't do any. They showed that there's been some peculiar big drop, that just on the basis of death certificates, 90% drop in mortality in the next 3-4 months. But to get some indications, I think I'm talking ahead of myself, because according to the outline that I made just a short time ago, before I went to Brazil, no, I did decide to tell you the story about Brazil first. I tried to determine the number between June and December. The number of reported cases of measles, the numbers of deaths, the numbers reported in the municipality, the numbers reported in the whole state, and the numbers that were admitted to a hospital. That's always, I found, a very good guide, because if a hospital admits 200 cases of tuberculosis, let's say, and suddenly it doesn't have any cases, something's happened. Well, here's what happened. Here's what I learned. And here's why this wasn't the whole story. And this is why I'm telling lessons that were learned step by step. Next slide, please. Turn out the lights, please. It's still too goddamn much on this slide. So I'll tell you what I prepared this slide for publication. First of all, that it's June 19 to December for different years, and I have 4 years. And there's no use taking averages. That doesn't help. You've got to see what the lowest number was, let's say, during a 4-year period. And this is the whole state of Rio de Janeiro. And during those 7 months, June to December, there was a drop of 66%, only 66% in the number of reported cases. And in death certificates, as determined, that's the only way you have, there was a 91% drop in death. And in a hospital that admits children with measles, San Sebastian, again, on the basis of the lowest year, and measles occurs in epidemic years, there was a 77% reduction in admissions to the hospital and a 93% reduction in deaths. Now, I'll have to go faster, so I'll go to the next slide, please. And the next slide shows whether or not, no, again, this is from June to December. What happened in other states? What happened in Minas Gerais, a state with 15 million people? What happened in São Paulo, the state itself, and São Paulo greater only, and what happened in all of Brazil? And again, based on the lowest year preceding 4 years, these are the data for 1985. Now, the state of São Paulo did show a 66% decrease, but in Minas Gerais, that gave additional measles vaccine to babies during the polio stage. Am I reading this correctly, that it's minus 1%? Yes. And this is minus 18% in São Paulo state, and minus 8% in the city of São Paulo, and for all of Brazil, it was plus 100%. So obviously something happened, very good, very sudden, very quickly. Now the question, did it carry over for the next year? And I'll tell you what happened, another thing before the end of the year, 1985. An analysis of the age distribution of reported cases in the previous 5, 10 years even, showed that a very large number of reported cases were not just under 5, they were under 15. And that foci of transmission among them occurred. And one of them gets into a school and gets coughing with measles, and pretty soon you've got the whole school with measles. So the director of health, the secretary of health, says, we'll start vaccinating the children in schools, the older children also. Well, it started off with a school named after me. It was named, that school was established almost 20 years ago. And big success, oh, big publicity, you know, they love that sort of thing. But it wasn't carried on. All right, but this has something. It shows an impact of a rapid mass vaccination concentrated on children without reference to whether or not they've had previous vaccination. I think the next slide, I'm doing it all from memory now, not looking at my slides, shows not what happened from June to December the previous year of 1985, but call attention to January to April. Did it continue? And again, I compare Rio de Janeiro, which with an inadequate coverage, with Minas Gerais, another state, São Paulo total, greater São Paulo. And here is the bottom line. the bottom line, and this is compared, of course, not with everything for the year, but only January to April that year, and there is a 74% drop in reported cases in the state of Rio de Janeiro, despite what was done. On the other hand, during the same period in Minas Gerais, there was a 40% increase, 51% increase in São Paulo, and 109% increase in all of Rio de Janeiro. And now if you'll put the lights out for a moment and let me take a drink, I will go to the next place. I'm a traveler where things can happen. Because during the year when I saw that it wasn't a complete job done in Rio de Janeiro, I went to the Dominican Republic and convinced the Minister of Health, then, who was a very good friend of mine, but they've had an election since then. He's been kicked out. He was also in prison during the Torrio. Well, never mind. The point was that he had decided to follow my recommendation that in the Dominican Republic, a small country, 6 million people, but spread out all over the place. When he put me in a helicopter and drove me around so I could get a bird's eye view, my God, many areas looked like the most primitive Africa. Of course, they're not too far from Haiti, and sort of divided up. Well, what they did was decided to give the vaccine to all children, regardless of previous history of vaccination, from 9 months to under 5 years. And they wanted to do it in a short time. In Rio, it was done actually in 1 day, 2 days. And they wanted to start at a time when Mr. Grant, the director of the Children's Fund of the world, would come and see how it's done and organized. Rotary promised to put up the money for the vaccine, but they didn't. They didn't come through. So they raised the money for the vaccine elsewhere, and they vaccinated a small region while Grant was there. Then they got money for more vaccine, and towards the end of, I think it was October, November, in a short period of time, no matter a few weeks, they gave vaccine to the vast majority, well over 90%. They said 95% of the children. Now, how do you judge an impact on a disease which the World Health Organization, in very careful surveys, says many countries report only 1%, some 5%, sometimes. How do you do that? So again, I picked out the hospital, the university hospital, the teaching hospital, and a very good director, Professor Mendoza, who had excellent records. How many children were admitted to the hospital month by month, week by week, with measles. And of course, the assumption that measles is as definitively diagnosed as smallpox, which is not sometimes definitively diagnosed, is an illusion. But still, there's less illusion in a university department, hospital. So I thought, Mendoza, let's go ahead and get some data from your files. Next slide, please. Thank you. Now let's read the top, because it's important. Number of patients with measles seen monthly. It doesn't say admitted monthly, because some of them were not too severe, were sent back. At Roberto Reed Cabral Children's Hospital in Santo Domingo, Dominican Republic, from 1984 to 1988, impact of this special national vaccination campaign at the end of 85 and 86, and then there's also 87. Now, the data were provided by Professor Hugo R. Mendoza. Please notice that 1984, it's important to realize that patterns are not the same in all countries. For this country, it's obvious, as you'll see later by comparison, that they have many cases year after year. So in 1984, the total was 585, 982 in 1984. Lots of measles vaccine being given during that time. It's not that they weren't vaccinated. And then over here was the main period of vaccination. And this is what I call rapid elimination. Not 20 years to influence the events in a country, but immediately, you see, down in a couple of months. And then they watched, and there were a total of 17 admitted, little ones that have pips on there, and then 15. And then in 1988, I haven't got the figures yet, but I left room. As soon as I get better, I'll get the figures. But what are these little pips? The same thing that occurred in Fege's reports, which he called imported cases. They weren't sure. They couldn't say it's imported cases. Are they measles? Are they not measles? They had no facilities for using IgM tests. And the important thing is that in the city of Santo Domingo, the capital, which has a population of, I think, 2 million, the contacts they had among private pediatricians, they weren't seeing any measles either. But let's see the next slide. When the reports from the whole country, from the interior of Santo Domingo came in, you see, sure, of course you realize the ordinance vary, but look, these are 4,000 and more, 4,000 and more, and it drops. But look at what happens. About 20 cases, you say, 120 cases, continue to be reported, much more than on the basis of the university hospital. Now, what are they? Well, there's no facilities for doing IgM, and the issue that emerges here and that will emerge next is how can you determine whether you can only control. Now, this is not bad, for goodness sake, even if 50% or 80% of it is now crud and not properly diagnosed measles etiologically, that if you can change in a country, if you can change from this to this, you've got control. You've got, number one, rapid elimination, continuing control. But one wants to learn more. So the next place I went was to Cuba. Well, it was a combination of things. I didn't ask to go, but for some unknown reason, maybe I have some ideas, Fidel Castro invited my wife and me to come to Cuba. But I knew that in Cuba, now Cuba now has a population of a little, oh, may I have the lights, please? We're leaving Santo Domingo, going to Cuba. We'll have a break. Cuba now has a population of about, thank you very much, 10 million. 2 million of them live in Havana. Havana itself has 12 children's hospitals. The health services in Cuba are really one of the prime achievements of the revolution, including education. So what they had decided to do in, I think it was October 1986, is to go all out and spend very limited foreign exchange, by buying triple vaccines, such as American pediatricians use. And they decided to have a campaign, not in 1 month, 2 months, not very rapid, but over a period of 6 months, from October 1986 to March 1987, 97% of all the children from 1 year now, 1 year of age, the babies didn't get it, small babies, from 1 year of age to, not mine, somebody's, to just under 15 years of age, received 1 dose of triple vaccine, that is measles and rubella, parotitis. Well, we got to study. I don't have charge of what goes on in Cuba. So I said, may I analyze the records in my way? And having had the experience of the hospital in, what the hell's going on here? Please, I said lights, not the last slide, with lights. I've learned long ago in the Army that you don't leave on a chart when you begin to talk about something else. Having learned that hospitals are a good indicator, particularly where reporting is bad, I said, let's go to the hospitals and see how many cases have been admitted before, after. And it appeared that already at that time, which was 1987, last year, they weren't admitting too many measles cases in the hospitals. And I had to we had to go to 5 different hospitals to get enough data to see what was going on. But they're not too badly organized. How many measles? So go the records, 1 separate section, measles. Didn't take very long. You saw cases admitted for measles every month. So now I decided to determine what a mass immunization program without reference to previous vaccination against measles, spread out over a period of 6 months in a population that they were using measles, but it wasn't good enough. What happened? Now I'll show you what happened. Next slide, please. And that's right. Now this is the number of children with measles in 5 Havana, Cuba pediatric hospitals in relation to the extensive vaccination campaign. And they also had some cases every year. And this shows the period during which vaccine was administered. And those who have good eyesight can see what proportion had been vaccinated by what time. But let's go for the whole 6-month period. And you can see that within about a month, it began to drop. And I keep getting reports, during the entire period here, there was only 1 case reported. Now, that's for the hospitals. And the next slide, please, shows what happened in Havana, Cuba. Reported cases that were not, in general, whether they were admitted or not. And here again, you see the period of vaccination. And you see again that in Cuba, they don't have years without measles vaccine, in contradistinction, without measles disease. And you see that during the period of vaccination, it was lower and lower. Then finally it dropped to about 2 cases, which certainly was low. Then there was 7 1 month here. What are they? Are they measles? Is that the way we're going to tell whether or not you get eradication of a disease like we have in this country? Anything that's is paralyzed. It's called polio. You'll never eradicate polio that way. Polio is caused by a number of other viruses. Paralysis is caused by other conditions, and you don't eradicate that. I discovered that also in Brazil. I found a number of states in my recent visit who've already eradicated polio caused by polioviruses. But at any rate, what's the relationship between Havana to all of Cuba? Next slide, please. Now, you will note that the scale is different. This is 0, 50, 100, 200, etc. And every year, and this shows the amount of vaccine that they have used, every year they have continuing measles, that's endemic measles. And after the vaccination campaign, it came down, but they still have approximately 30 cases a month of measles. Is it measles? Well, I asked them, after discussions, they were having such small numbers of cases reported. The suggestion was that why not admit every case of suspected measles, take blood on admission, and perhaps another one a week later, and test for IgM antibody. First, it took a long time, and then in March, they started drawing blood like this, but still no results. I have a sip of water. I'll tell you, I'm quickly reaching an end point. No results. How are they going to test for IgM? Did they know anything about testing for IgM measles antibody? Well, my communications are through the local representatives of Czechoslovakia, and I get quite a lot of information about Cuba, but not enough. So then there was another place where I was able to have some influence on general policy. Lights out, please. Lights out, please. Lights on, please. Excuse me. Some of my medication turns me around a bit. I've got to tell you something about Sao Paulo. Anybody who thinks of Sao Paulo as a developing country gets his biggest surprise when he first flies into Sao Paulo. It's the richest, most developed state in all of Brazil. It has about 31 million population now, has the biggest income, the biggest production. But the difference between a developed country like the United States and a developed country like Sao Paulo is the proportion of poor people. No country is without poor people. Many of our own problems in this country are directly related to the pockets of poverty. And unless we go around looking for the pockets of poverty and concentrate there, instead of teaching elementary school children about condoms, and instead, excuse me, I'm kind of sensitized about this, or going around and teaching, giving health education, so to speak, seek out the pockets of poverty and where they are. And I'll show you at the very end how that applies to measles also. Well, I've been going to Sao Paulo for some time. I first went to Sao Paulo in 1927, and that's where one of the first mass vaccinations against polio was carried out. Well, they vaccinated at a very high level, particularly children under 1 year of age, for many years, so that by the time you came, let's say, in 1987, every child should have had should almost have been vaccinated. This, incidentally, is the WHO expanded immunization program. Push for enhancement, reach higher, go from 50 to 60 to 70. And if they think they'll get anywhere by 1990, they better dig their graves now. I'm sorry. All right. So what do they do? I don't make policy in São Paulo. I try to influence it. So it was decided that after a period of all this activity they had, they carried out a wonderful Gallup poll kind of survey by selecting 40,000 homes with children distributed, the proper age and so on, and checking how many measles cases are actually recognized by mothers according to certain criteria as compared to what is being reported. And they found that during non-epidemic years, because they have some years that are low and some years that are high, that during non-epidemic years, 100 times more children under 15 years of age had measles that were hospitalized, because they reported only hospitalized cases. And during an epidemic year, when there was really a lot, the difference between reported and hospitalized was 33-fold. And it was quite obvious. They also found that where it was reported that 100% were getting, children under 1 year of age were getting vaccine, that's what they call living in the real world, not staying in your laboratory and pontificating about what happens when you got some. Why did I say that? My subconscious pushed me. Well, anyway, they found that 20% fewer children were actually being vaccinated than the official records showed. How does that happen? You've got to get out of the lab, God damn it, and go where the action is if you're going to solve a problem. I'm not saying that measles is the only problem that presents this. There are others also. But what they found is this. You deal with clerks, and how you teach your clerks makes a difference. And if the clerks counts up the number of empty bottles and the number of cases that appeared and says that's how many doses we used, it's absurd. Well, at any rate, they found that although certainly a large number of persons were vaccinated against measles in São Paulo, it was not good enough. They kept getting epidemics. So in 1987, just a year ago, they decided between May and June, middle of May, middle of June, to set up stations and vaccinate all children from 9 months to less than 15 years of age, regardless. Well, São Paulo is a highly developed state, so they also have strikes and cutouts and everything, so things didn't go well. But nevertheless, they were able to vaccinate more than 8.5 million children within a month in municipality, Greater São Paulo, and the interior. And now I'm going to show you some of the things I learned when I put the data together. I was in São Paulo in November. Yes, sir, thank you. We're coming to an end. I think I will last out, and so will you. Measles vaccine administered to children 9 months to less than 15 years of age in different parts of the state. São Paulo during the special campaign, vaccine given to all regardless of previous history of vaccine or disease. Now, the region is divided to municipality, the remainder of Greater São Paulo, and the interior. And the figures that are given there, the estimated population, is for how many children there are from 9 months to under 15. And you see they vary. But you have a total of almost 9.5 million. And the doses of measles vaccine that were given to this age group was about this much, which comes to 91% for the whole state, 97% for the interior, 99% for the remainder, and only 78% for the municipality. But all you blooming epidemiologists, you've got to learn how to look at such figures critically. And the critical thing is that when you have a report for a whole region of 99% coverage, that may vary from 57% to 125%. It means that in some areas, the certain age group wasn't covered enough. In some areas, all age groups weren't covered enough. But in other areas, either because of the strikes and whatnot, children were brought so that there were more than estimated, or the estimates can't always be accurate. In other words, this is a terribly important part of the analysis. When somebody says in a country that we have vaccinated 100%, this was the first report that came out of Brazil. What's my monitor say my pulse is now? I better slow down. All right. The point is that the meaning of it is you've got to look at these districts because these are potential foci of continued persistence and dissemination of the virus.